Workshop number 3, our panelist, Dr. Ashok Kumar Vaidya. He's a senior nephrologist, Paras Health, Ranchi. Please welcome, sir. Dr. Pratik Das. He's a renal transplant physician, R. Tagore, Kolkata. Dr. Vivek Goel. He's a senior nephrologist and kidney transplant physician, Apollo Hospitals, Kolkata. I would like to call our moderator, Dr. Manish Jain. Dr. Manish Jain, he's a consultant nephrologist and kidney transplant, Apollo Hospital. And our chairperson, Dr. Lalit Agarwal. A round of applause for him. He's a senior nephrologist at Woodland Hospitals.
So good afternoon everybody, and I like to thank the organizers to inviting me in the AAPONCON Kolkata 2024. So I will discuss the management in different stages of the CKD. As you know, the CKD is a very common problem. About 5 to 8% of the patients of the world suffering from the chronic kidney disease, and about 50% of patients are above the 70-year-old age. Most of them remain stable. But when we come across a patient with altered renal function, we need to evaluation of this patient, including the diagnosis of CKD, their etiology. Then we have to take steps to prevent the progression or halt of the disease, and subsequently preparation of the patient for further treatment if required, the RRT on transplantation. First, we need to define the CKD. The CKD is defined as the structure and functional abnormality of the kidney for more than 3 months, as manifested by the one is the kidney damage without decrease in the GFR as defined by pathological abnormality. Markers of kidney damage including the urinary abnormality like proteinuria, blood abnormality like renal tubular dysfunction syndromes, imaging abnormalities, and the patient with kidney transplantation always in the stage of CKD 2 or 3. Our patient has GFR less than 60 ml per minute per 1.73 meter surface area with without kidney damage. After that, we need to define the stage of chronic kidney disease. Kidney disease divided into 6 stages according to GFR. Stage 3 defined in 3A and 3B. Subsequently, each stage had graded according to albuminuria in the mild, moderate, and severe disease. You can see in this diagram that the patient in the early stage, like green, or marked in the green, has very mild disease or very less chance of progression disease, but the patient who marked in the red either have very advanced disease or a very high chance of the progression disease. Most of the patients of chronic kidney disease generally we see either in the stage of 2, G2 or stage 3A, and the patient in the last stage is stage 5 or ESRD are generally considered 0.2% of the total patients. During the evaluation, we face some of the problems, including regarding the investigation, etiology, and management. For we discuss, we have our panelists, and I first one common problem we have the cyst in the kidney. A lot of the patients come as to us when during the incidentally they found a cyst in their kidney in the ultrasonography, and they come to us. Generally, most of them remain NGS. So I will ask Dr. Pratik Das, as the cyst are structural abnormality, they remain to persist. Should a person with cyst should be labeled as a suffering from CKD or rendered unfit for the job?
So many times patient comes to us and with a incidental finding of a cyst in the kidney, and they ask what may be the prognosis, what is the next outcome, and also they sometimes sent by this they are appointing persons. So if a patient comes to us with a single cyst, then and it appears to be in the ultrasonography a simple type, then we initially ask them whether you have a family history or not. In absence of their family history and nothing inside the cyst other than the fluid in the ultrasonography echogenicity, and if this is single, that is fair enough to tell them you are not suffering from any significant kidney disease, and also we can certify them for as a fit for surgery without kidney disease for the job purpose or maybe the insurance purposes. But if the cysts are multiple, if the cyst contains something solid within this, or the cyst and he is planning to donate kidney for somebody, then we need to evaluate further. Evaluation should be done firstly in terms of they are doing a CT scan, and or maybe sometimes MRI. CT scan is much more preferred, so that the cyst size and this cyst insider that can be detected. We sometimes see that there is a Bosniak classification 1, 2, 3, etc. These are all CT findings. If they tell this is a single cyst, it's a simple cyst, nothing solid inside it, then you're fair enough to go to the normal job with the yearly follow-up. If something is there, there may be 2F, maybe 3, 4, there is a possibility of malignancy conversion in the future, and in those cases they may need a surgery or a frequent follow-up for a single cyst even. But if the CT scan detects that there is much more than one cyst, maybe one cyst detected in the ultrasonography, but the CT scan detects 1, 2, 3, 4 bilateral cyst detection, when the suspicion of a familiar or a familiar cystic disease is high, in those situations we may suggest them to go for a genetic analysis for these cystic diseases. So the bottom line is, if a single cyst and nothing inside is ultrasonography enough, assurance is enough and no denial from the service. If there is a family history, probability of organ donation, if there is a complications within the cyst or anything, multiple cysts, that should be evaluated by a CT scan. Even after that, you will decide according to the plan of treatment and according to follow-up. But multiple cysts, bilateral cysts, solid cysts, these requires evaluation. In those cases, they may not be stamped as a CKD, but in some situations. And another thing is the cyst is the normal development with the aging process. So in a person who is a 65 years of age comes to 1 or 2, 3 cysts, this may be degenerative cyst. They also should not be stamped as suffering from CKD, and most of the cases they do not even need any evaluation. But the evaluation is needed if patient is on dialysis and having some cyst in the kidney. We call it an acquired cystic disease. That is a dangerous thing. That should be looked upon very seriously, and they may convert into malignancy very frequently, and they need a treatment whenever there is a solid material developed within the cyst. So answer to the question, they cannot be rendered unfit for the job, neither they should be stamped as a CKD if there is a single cyst.
I think most of the questions regarding the cyst Dr. Paridas had defined and very nicely. Another commonly test we are doing the urine albumin to creatinine ratio. So my question with the Dr. Vivek Goyal is that, what is your opinion on the UACR as an early marker of kidney damage in type 2 diabetes? And should all the patients with type 2 diabetes should be regularly screened for CKD, and what is the guidelines?
Good afternoon to all. So the urine albumin creatinine ratio should be done on all diabetic patients, even at the time of diagnosis. We do know that approximately 20% of diabetic patients at their diagnosis are found to be having some or the other kind of nephropathy. Now, if we follow the Mogensen staging of the diabetic kidney disease, we know that there are 5 stages. Namely, first is the stage of hyperfiltration, then the silent stage, then the microalbuminuria, then the macroalbuminuria or the overt nephropathy, and next is the end stage kidney disease. So this is the typical progression of a proteinuric diabetic kidney disease. So we know that the first 2 stages are preclinical. So a patient may not be having any signs or symptoms, and it is very difficult to even detect them because the eGFR and both the urine examination will be normal. But the incipient nephropathy or the stage of microalbuminuria can be diagnosed only by the UACR examination. But we also need to keep in mind that another phenotype, that is a non-proteinuric kidney disease, is growing day by day. Approximately again 40% of type 2 diabetics could have a non-diabetic proteinuric kidney disease. So the linear relationship which we early used to think between the UACR and the eGFR may not be holding true. Also, if we do a urine dipstick examination, we know that there are 2 fallacies of the dipstick test. One, it does not detect a non-albuminuric protein, and number 2, it can miss microalbuminuria. So the range of 30 to 300 milligrams per day proteinuria is missed on a dipstick. For that to be caught, we must do a UACR examination. All the guidelines, that is the ADA, KDIGO, they recommend that at least once a year, the UACR and eGFR must be done on all diabetics. And as the stage progresses, the frequency should be increased. So, sorry? No, sir. That's a spot urine albumin creatinine ratio.
I think we can clear our doubts in the last when all the panelists will be there in the completion of the models.
May I ask one question?
After in the last, you can keep your question.
Really?
Okay.
See, suppose a patient comes with a blood sugar of say 400 and blood pressure is again uncontrolled, say 200 by 100. Shall we do the UACR in the first visit or after the blood sugar comes down to a little bit control stage, and also the blood pressure, because the protein excretion that also depends upon the, I mean, uncontrolled blood sugar and also hypertension. And second question is that like the undetected urinary infections, it is often present. So before going for UACR, will you go for a routine test, or it should be done?
So before answering sir's question, there are a couple of fallacies with UACR examination as well. So spot urine ACR can differ day to day depending upon few variables. Say a female who has completed a menstruation recently, a person who's done a lot of physical exercise recently, even prolonged standing on the day previous or the day before can cause a different UACR. In fact, a spot UACR given in the morning time could be different from the evening time, because there is a diurnal variation in the protein excretion as well. So that is why the KDIGO recommends that only if 2 out of 3 samples, 2 out of 3 reports of the spot urine ACR are confirmatory, should you designate it as microalbuminuria. Now, sir's first question, irrespective of the sugar status or the blood pressure status, we should do a spot urine ACR at the onset of the diagnosis, because that is a chronic process. A incidental or one reading of a high blood pressure or a high blood sugar should not be causing a significant variation in the UACR value. And as sir said, that especially a female could be having a UTI as well. So that is why what I do is always I do a urine routine and ACR together. And if there is significant pyuria, then of course that has to be interpreted accordingly. And when the urine is pus cell free, do I interpret that urine ACR as the correct one?
Any more question? Okay. So another test we generally perform is the EGFR. You have seen the staging done according to EGFR. So when you do practice, many times we have trouble with how we can measure GFR within the clinics. So I will ask Dr. A.K. Vedya of various formulas to calculate the EGFR, which formula should we one prefer to use?
As you have seen in presentation, the different staging of CKD, and that is based on 2 important parameters. One is EGFR and second is albuminuria. Albuminuria, you have just listened from Dr. Vivek. Now the EGFR estimation is very important for each and every patient who comes with CKD to do the staging of CKD. Now we have different formulas. Roughly more than 60 formulas are given by different institutions. But 3 important parameters for formulas for adult patients who are more than 18 years of age, we discuss about 3 formulas. One is GC formula, that is Cockcroft and Gault formula. Second is MDRD formula, and third one is CKD EPI formula. So, and all the 3 formulas basically use 3 important parameters. One is serum creatinine, second is age, and third is sex. GC formula that also includes weight of the patient, and this formula is used by clinician for drug dosing purpose. Second formula is MDRD, which is supposed to be better than GC formula because it is more accurate than the GC formula. But the fallacy of that MDRD is that when the GFR is more than 90, probably it overestimates GFR. So that is the fallacy. And then we have the third one, that is CKD EPI formula. And this formula has been revised in 2021, and that is supposed to be the best formula for clinical use. Because even in higher GFR, it gives accurate measurement of GFR. And that was the reason when both the formula was compared, MDRD versus CKD API formula, the prevalence of CKD in general population with the MDRD formula, it was 13% approximately, but with the calculation of GFR with CKD EPI formula, the prevalence came down to 11%. So that is the beauty of CKD EPI. So we usually prefer CKD EPI formula in adult patient to calculate the eGFR. And this is for adult patient, and for patients with less than 18 years of age, we have one important bedside revised Schwarz formula, and that is very simple formula, 0.413 multiplied by height in centimeter divided by weight in kg. And this formula is usually used when the age of the patient is less than 18 years of. Now, this formula is important, but it should be used only when the serum creatinine is stable. Like in AKI patient, you cannot use this formula where the fluctuation of creatinine is day by day. And second important thing is that when the patient has got severe malnutrition, there's muscle mass reduction, or if there's amputation, this formula is not useful. So these are the 4 formulas. Out of these, CKD EPI is best for the adult population, and revised bedside Schwarz formula is for the patients with less than 18 years of age.
Thank you.
Excuse me. One thing I would like to add here, now we have latest CKD KDIGO guideline 2024. Here they have again mentioned that to increase the specificity and sensitivity and to more to get the more accurate results, they have added cystatin also. So they have said that you calculate the average of creatinine and cystatin as the marker and then calculate it.
What about in the old age patient?
Practical purposes, I think for the practical purposes for us, cystatin, the major drawback is that it's very costly, and at the moment it is not possible for the general population. It is used basically for the research purpose.
No, I mean this is the guideline, latest guideline by the KDIGO 2024 CKD guideline. Just when we are discussing, I am telling it. Maybe in routine practice it will gradually come.
Okay. Thank you. Now another very practical question generally we face in the old age patients who come with a mild rise in the creatinine with a very low GFR. So what to do in this patient above? Should we label them CKD, and how will we manage this patient? Dr. Pratik Das.
As you have heard that all these formulas are basically based on the creatinine based formula, because creatinine is easy to measure, it is very stable, it is not utilized by the urinary tract, and it is very cheap, because all other things which is handled by the body in the same way are very costly. So wherever this creatinine is, because creatinine is stable, because it is produced by the skeletal muscles. So if you have a larger muscle mass, the creatinine is more produced, and if the muscle mass is less, creatinine will be produced less. So anything which is associated with the muscle mass, that will be fallacy, because a very heavy male person, young male person with a 100 kg body weight with a huge muscle mass may have a creatinine of 1.5, even then their GFR of more than 60. But in the same time, a 80-year female with a 35 kg body weight with a very low muscle mass may have the 1.5 creatinine. At the same time, there may be a GFR of maybe 25. So this is an important issue, as all are said, that if the muscle is not proper, suppose the patient is very lean and thin, patient may be amputated, he has taken a lots of cooked meat in the previous night. In those situations, there is fallaciously high or fallaciously low. In those situations, there are 2 or 3 options to get closer to that. One is, as Dr. Agarwal was taking 2021 modification, they have included both this creatinine as well as cystatin as a combined formula, creatinine cystatin formula, which utilizes some part which coming from the muscle, some part which is not coming from the muscle, to get closer to the GFR, particularly in the low built persons. Secondly, in other cases, to estimate the GFR of such patients, you have to directly measure the GFR. As long as we are discussing, these are all estimation of the GFR. That is, formula is used to get the GFR. You can always measure the GFR by doing a 24 hours urine creatinine clearance. That will include a serum creatinine which is coming from the muscle. At the same time, the renal handling of the creatinine by the kidney. So if you measure this 24 hours creatinine clearance, you may be slightly more closer to the GFR, as maybe may not be accurate, but closer to that. Otherwise, we have to utilize the other methods for estimation of the GFR. That may be a DTPA, that may be also estimated. You can do a DTPA renal scan. DTPA scan can other methods, which is not a creatinine, which not dependent upon your muscle mass, not produced by the muscle, but an artificial thing that you are injecting and getting the result how the kidney is excreting. So in such cases, specific situation, lean and thin person, elderly persons, in those situations, if you want to get an accurate GFR, in those situations, you can utilize either of these three. The creatinine cystatin combined CKD EPI formula, 24 hours urinary creatinine clearance formula, or maybe a DTPA GFR. But all said and done, this is not possible all the times. It is always, you have to remember, that is a thin person will always show you falsely a low creatinine value. You have to be very cautious with slight change of the creatinine, suppose 1.5 to 1.8, maybe a loss of GFR of maybe 15 or 20. So in a heavy persons, you are comfortable with a high creatinine and the formula. In a very lean and thin person, you are not comfortable with the formula because they have a very low creatinine with a very low GFR. So this is the point in this situation, special maybe I can do that.
As we know that according to either GFR is decreased 0.1 ml per kg weight,
Yes.
1 ml per
That is also important because we have a natural.
when you will label them CKD or not? When there is something else we have to see.
Yes. So like always we say that some people coming with a eGFR, because in every report now there is a mentioning of the eGFR. Creatinine is 1.1 and eGFR is 45. They always ask, this is a CKD or not. So this is a nature's call. Basically, like after the age of 40, there is a decay in the kidney function. So the GFR, suppose it is 80 at the age of 25, we lose 1 ml of GFR almost every year after the age of 40. So if you start from 90, when you reach by the age of 75, by this time your 35 ml GFR is lost. So even you give a report of creatinine 1.1 with a GFR of 45 at the age of 77 years male, that should be considered as a normal. They should not be stamped as a CKD. But the elderly patients, these are not always safe, because as they are losing their glomerular or filtration mass or the effective glomerular mass with the age, they are more vulnerable. Kidney failure happens to the vulnerables. Not all people affected are the kidney failure. So they becomes more vulnerable. A slight change in the diarrhea, slight infections, pneumonia, upper respiratory infection can precipitate the significant renal damage, even a dialysis requiring AKI. So you should be very cautious. Tell them, assure them, yes, you are not suffering from CKD, but your reserve is not there. So any sort of crisis, you should get checked for the kidney failure and get treated as fast as possible.
Here I would like to add one thing, one comment, like up to 70 years of age, we have stage 1 to stage 5. So stage 1, stage 2. So in elderly, we say that he is suffering from CKD if the GFR is less than 60. And this has been clearly shown in the latest KDIGO 2024 guidelines. So in elderly above 70, if it is less than 60, then only you can say that it is CKD, not 90.
Okay, thank you, sir. Thank you, our expert. Now, very important question: how to manage in patients with CKD, especially with diabetes 2, and what is the pillar-based treatment, and what you perceive if any on with the current guidelines recommendation, Dr. Vivek.
So the pillar-based approach in managing CKD and type 2 diabetes, we know that diabetes and diabetic kidney disease is a heterogeneous disease. So the management also demands a multi-systemic approach. First and foremost, the base of the building should be given by smoking cessation, weight control, leading a healthy lifestyle, and doing proper exercises at least 5 days a week. Then comes the first floor of the building should comprise of management of diabetes, The first line drugs for diabetic management in a CKD are metformin, provided the EGFR is more than 30, and SGLT2 inhibitor, provided the EGFR is more than 20 mL per minute. The blood pressure management should be done first and foremost by an ACE inhibitor or an ARB, and to add to it, we must add a moderate intensity statin if the patient is more than equal to 50 years of age. The second line or the second pillar must be founded by additional drugs, that is in diabetic management. We could add GLP-1 analogs if we have not achieved the adequate HbA1c targets. And for the blood pressure management as well as for other things, we could add a non-steroidal mineralocorticoid receptor antagonists if the EGFR is more than 25. Coming to the antiplatelets, of course, we add only if the 10-year ASCVD risk is higher, not to all patients. Last but not the least, there comes the role of other drugs now. A lot of drugs are coming, and so this is the approach.
Okay, so should you add all drugs like ACRB, Findinone and SGLT simultaneously, or you want to go step by step?
So this is again a big controversy. Even I had asked Dr. George Bakris, the key investigator of the Findinone trial, when he'd come over to our country for the ISN meeting, and he said that he adds all the three together. ACE inhibitor, ARB, SGLT2 inhibitors and Findinone, all of them together. But again, there is a conservative approach also, which I follow mostly. I sequentially add them. So first the ACE inhibitor ARB, the maximal tolerated dose, then the SGLT2 inhibitors, and then the non-steroidal MRAs. So if the patient cannot tolerate a SGLT2, you would not add Findinone? Sorry, sir? If a patient could not tolerate a SGLT2,
Hello.
so you would not add a Findinone because you want to go step. Sir, I would add, I mean, if the patient is having a pyelonephritis or a UTI, active, maybe a fungal infection, I would withdraw SGLT2 inhibitor. And definitely, any CKD diabetic patient who has an EGFR of more than 25 and a UACR of more than 30 is a candidate for Findinone.
So above 60, you are not going to add Findinone?
Sir?
Above 60 GFR, you are not going to add Findinone?
Yes, sir, why not?
So what
more
is,
than 25 is the cutoff.
So any patient who is diabetic and say a GFR of 17, no microalbuminuria?
No, no, sir, at least the patient must have microalbuminuria.
Must have?
Yeah, if you see that trial, Fidelio, the pooled analysis of Figaro and Fidelity. So if you see the trial, they have taken diabetic patients with CKD. Diabetic patients without CKD, no Findinone.
So CKD means 60 GFR?
It is based also on albuminuria as well as GFR. GFR less than 60 and albuminuria, either micro or macro.
So he said that 70 GFR and microalbuminuria he'll add.
But trial, as per the trial,
Yes.
it is less than 60.
So above 60, if there is no macroalbuminuria, there is not too much of a role of a Findinone. Findinone is added if the GFR is above 60 and macroalbuminuria. Below 60, diabetes, microalbuminuria, yes,
Exactly,
I would add
exactly,
Findinone.
exactly.
But if it is above 60, then it has to be macroalbuminuria to add Findinone, not
True.
with microalbuminuria you would add. That is the Fidelity trial which says.
One question, Dr. Goyal. We are not nephrologists. So in our practice of diabetes, though we have been taught that AC and ARB are not nephrotoxic, but up to what level of the creatinine we can safely use it if the potassium is normal?
Sir, this was the first question I ever asked my senior when I entered MD medicine in IPGMR and SSKM hospital. And I still remember he also could not give me a clear-cut answer. But there is no GFR limitation as to which ACE inhibitor ARB should be given or cannot be given. The only limiting factor is potassium. If the potassium is less than 5, we can add ACE inhibitor ARB even in CKD5. In fact, even in dialysis patients, recently I encountered a dialysis patient who was having refractory hypertension. Despite adding 5 drugs, his BP was not controlled. I added 1 telmisartan, his BP came down. So we can add ACE inhibitor ARB up to any level of CKD, provided the potassium is within normal limit.
There is a recent publication in 2023, the use of ACEs and ARBs in advanced CKD. And that is as GFR of less than 20 they started. And what is the advantage? That they concluded that the chances of heart failure, MI, CVA, that becomes significantly less even if you use an advanced CKD. But at the same time, there is a there is an acceleration of the initiation of the dialysis. Rest of the renal function deteriorates very fast, and the timing of dialysis becomes slightly earlier. So it is a win-win situation. If there is a cardiovascular risk and CV risk is very high, you continue it. But keeping in mind that if you could have been waited for 6 months or 1 year before starting dialysis, now you will wait only for 3 to 6 months only.
Actually, this area is very much controversial. There are papers which is for starting ARB or ACE inhibitor during the late stage, and there are papers which suggest you start it. I mean, if you start it, you can delay. Like what Dr. Pratik was saying, that you can accelerate the onset of dialysis, whereas there are papers which suggest you can delay even when you start at the stage of 4. So this area is a bit controversial, but the bottom line is, if it is clinically indicated and hyperkalemia is not a contraindication, you can use it.
And the major thing is that it's not only kidney. It gives organ protection basically, cardiovascular protection, vasculopathy protection. So AC inhibitor AR, that should be continued till the patient tolerates it.
Role of prebiotic and probiotics in CKD management.
That will come now. This is different question.
Yes.
If there is no problem with potassium, because finerenone is a costly molecule, and if potassium is normal, say less than 4.5 or 4.8, can we give spironolactone instead of finerenone? Because finerenone is being costly, every patient cannot afford. And if there is no problem with potassium, can we give spironolactone as a renal and cardio protection?
So, sir, in patients who have a normal ejection fraction and patients having diabetic CKD, spironolactone is much inferior to finerenone, because if we study the pharmacology of spironolactone versus finerenone, it is a steroidal MRA, which is a non-selective MRA with a longer duration of action, having higher incidence of hyperkalemia, higher hormonal side effects like gynecomastia. Whereas finerenone is a selective MRA which is non-steroidal, having lesser hyperkalemia and having lesser hormonal side effects. But sir, honestly, I have seen prescriptions of very senior nephrologists before finerenone. They used to use spironolactone and they would get a lot of effects, good effects as well.
Actually, spironolactone, it is the 4th antihypertensive of choice nowadays. Most of the societies are now saying that if you have uncontrolled hypertension, resistant hypertension, like you are not able to control with 3 drugs including a diuretic, then the 4th drug would be a spironolactone. And when you are able to manage hyperkalemia with spironolactone and your blood pressure is well controlled, carry on with this. So that is the role of spironolactone as a 4th drug in patients with resistant hypertension.
And also the quite significant number of young patients we do have an chronic interstitial nephritis. They have a good urine output, normal blood pressure, even as a low potassium. In those situations, you cannot give an ACE or the ARB because of the low potassium situation. In those situations, if you want to give an RAS blockade, then spironolactone may be helpful. But keeping in mind not only hyperkalemia, this also induces asymetabolic acidosis. So that needs to be also taken care of. So many young patients with chronic interstitial nephritis, they get spironolactone for their renal benefit and RAS blockade.
Okay, I think in night discussion. So as we discussed, hyperkalemia is a problem with some drugs, including the spironolactone and finerenone. So what is the risk of hyperkalemia in patient receiving finerenone, and how will you mitigate mitigation strategies for this hyperkalemia and CKD, Dr. Vidya?
So already some of the aspect of hyperkalemia has been discussed. So it had made my task very easy. Now the hyperkalemia does occur with finerenone, that every one of us know. And the Figaro study that have shown that the incidence of hyperkalemia in finerenone group is mild hyperkalemia is 21.4% as compared to the placebo with 9 point something percent, 9.5% something like that. This is mild hyperkalemia. If you go to the moderate hyperkalemia, the incidence is 6.5 versus 3.9 as compared to the placebo. And severe hyperkalemia, the incidence is 3.5% versus 1.7%. That means the incidence of mild hyperkalemia is more in Finrenon group. And if you compare it with the spironolactone, one study have shown that the incidence of hyperkalemia with spironolactone is 64 point something percent. So the incidence of hyperkalemia with spironolactone is too much high. And even if you give spironolactone along with potassium binder, even then the incidence of hyperkalemia is roughly around 40%. So in that way, Finrenon is much safer than spironolactone. That is one. Now, and even if the hyperkalemia, that is mild one. And the same study have shown that discontinuation of therapy is minimal with spironolactone, and mortality is almost negligible, hardly 1% or something like that, due to hyperkalemia because of Finrenon. Now, how we should initiate the therapy and what should we do once the patient develops hyperkalemia? When the potassium level is less than 5, the Finrenon should be started. If the potassium level is more than 5, it should not be started. And once you have started after 1 month, serum potassium level, that should be done. And again at 4th month, serum potassium should be done, and then it should be done at every 4 months in a routine way. This is the protocol. But if the potassium level is less than 4.8, then you can increase the dose of Finrenon from 10 to 20 mg. But if the patient is already on 20 mg, just continue with the same drug. And third important thing is that when the potassium level is more than 5.5, you stop the Finrenon for some time, and when again the potassium is less than 5, then you restart the Finrenon. That is very, very important, because this is such a wonderful drug. The benefit of this drug should be passed on to our patients. Now, once the patient develops hyperkalemia, then what should be done? One is either you reduce the dose of drug, or you discontinue the drug for some time. And regarding the dietary management of hyperkalemia, the recent guidelines says it should not be used as a preventive measures. Like if you have started Finrenon, and at the same time you have given a chart of low potassium diet, that should not be done. Once the patient develops hyperkalemia, then you give as a treatment dietary management of hyperkalemia. That is very important. And again, I have told that if the potassium is more than 5.5, then it should be stopped for some time. And if the patient develops hyperkalemia, and again you have restarted the therapy with Finrenon, then the monitoring of potassium should be more frequent at an interval of 1 to 2 weeks. And you should keep the serum potassium level less than 5.5. So dietary management, then stopping the drug. Third important thing is the correction of metabolic acidosis. And sodium bicarb should be used because acidosis increases the incidence of hyperkalemia, and once you treat the acidosis, it will decrease serum potassium level. But again, here there are some studies that says that instead of giving sodium bicarbonate just to correct the hyperkalemia, you should use the dietary management, like giving a high fiber diet, and which will improve the metabolic acidosis hyperkalemia. So I think this is all about mitigation of hyperkalemians.
Oh, one thing I would like to add here in the Western world, because this molecule, this medicine is so good that in terms of cardiorenal protection, they are using patiromer along with these medicines to avoid the side effects of hyperkalemia. So patiromer is a potassium binding. No, whatever it is, I mean the guidelines, when we are talking about the latest developments, I think we should not think about the monetary part right now. So they are using patiromer along with the finrenone to avoid the side effects of the hyperkalemia because of this medicine. Because K-bind, which is available in our country, this is not good in terms of long term, but you can take patiromer. It's a new molecule going to be soon, coming soon in our country also. So people are using this along with this molecule.
So, problem of hyperkalemia, for any side effects, if you stop a drug, problem is not stopping a drug. You are aware that finrenone or spironolactone can cause hyperkalemia, you are very stringent monitoring and stop the drug. Problem is the restarting of the drug. Either we doctors are also not confident whether we restart, and patient will not allow you to restart the drug. That is the most important thing. So in that situation, before stopping a drug in the hyperkalemia, there are so many causes of hyperkalemia. Person taking the blood from the Sirampur, taking a Lal pathology lab in Salt Lake, and in the meantime there may be a destruction of the blood and causing a pseudo hyperkalemia, and by that we are stopping the drugs. So hyperkalemia, if you see the guidelines of the KDIGO, stopping of the drug guidelines are very stringent. But they have asked not to stop the drug, not because it is harmful, because you cannot restart again. So before stopping, stamping as a hyperkalemia, you should look after the other reversible causes of the hyperkalemia. And for the long term use, yes, this is one option. Now patiromer is not available, and it will not be available in next 2-3 years time, but sodium zirconium cyclosilicate, that will be available in the market probably in next 6 months time. That the cost is an issue. The 1500 rupees per day is a one tablet cost, so powder cost. So it is there will be grossly non-compliance to that system. So that we should exclude pseudo and other causes of hyperkalemia before you stop the drug. Once you stop the drug, it will be very difficult to restart.
Hello.
Yeah. Yes.
Sir, in a patient of diabetes with only cystatin C high, with no other features of CKD, is it justified to start finrenone?
But cystatin C alone for the estimation of GFR has a very
because nowadays some
sensitivity and specificity both are very abnormal. Until and unless you combine it with other equation or formulas using creatinine or maybe other things, iothalamate, this is a grossly inadequate. So based on this only cystatin, it is not fair enough to start any of these drugs. Probably finrenone is of course is a costly and a specific drugs, where the guidelines are very stringent.
I think in the old age patients, cystatin C is very good for measurement of GFR, but in other age group, they are very controversial. Now, we come to complication of the CKD, and I will ask Dr. Pratik Das, as the anemia is very common problem, when should we start erythropoietin while managing anemia in CKD patient, and what should be the starting dose of the erythropoietin, and how should that dose should be titrated?
So guideline tells that whenever there is a CKD and the development of eGFR is less than 60, in those situations you should evaluate the patient for anemia, and evaluation starts with the ferrokinetics for all patients. Testing iron, testing and transferrin saturations and ferritin is a must. Because many of the patients not taking food on time, they have absorption abnormalities, and they may be occult GI loss. Many of them is suffering from this low iron level, and that should be corrected first. And once you cannot achieve the hemoglobin of above, because guidelines are slightly on the higher side, but in our practice, when it is above 11, we don't start actually any kind of this kind of erythropoietin stimulating agents. But if GFR is less than 60, your ferrokinetics is acceptable, there is no iron deficiency, and your hemoglobin is less than 11, then you should start any of these agents. It may be an erythropoietin, it may be a darbepoetin, it may be a SERA, or maybe newer drugs, maybe PHI inhibitors. And the dosage should be different for everyone. Commonest one is erythropoietin. You can start with 100 units per kg body weight per week, and we can winding it that is a short half-life. That should be given a subcutaneous dose. Intravenous dose is slightly higher, and you can give it 2 to 3 times in a week. That is better. If it is a darbepoetin, the mechanism is almost same, but the duration is slightly, duration of action is slightly more, so you can give once or once in a week or once fortnightly, that may be enough. And in cases of the newer drugs like HIV, PHIs, they have not decided, but they have a shorter half-life starting from 6 hours to 18 hours, so they should be given every alternate days. So we start these drugs with a target of keeping the hemoglobin above 11, because if you overcorrect the hemoglobin by giving the drugs, there may be a chance of this excessive erythropoietin-induced thrombosis, seizure, because of epifistula blocker, CVA, MI, thromboembolism. So hypertension and chances of death will be increased if we use it inadvertently and not monitoring. So we start below 11, monitor every 15 days to 1 month time. Correction should not be very fast. Hemoglobin rise more than 1 per month is not acceptable. And if it goes around 12 or 12.5, we should stop the drug and monitor the patients for this.
So when there is a, Dr. Vivek, when there is a poor response to erythropoietin, I think you see a lot of the patient what, despite the advocate of erythropoietin not achieving the target hemoglobin level. So what could be the causes of this erythropoietin hyperresponsiveness? You work out in these patients.
So it is not uncommon to see erythropoietin hyporesponsiveness. But before we label a patient to be hyporesponsive, we need to understand that what is the optimum dose of EPO that must be given to a patient before labeling him hyporesponsive. So KDIGO defines EPO hyporesponsiveness as inability to reach the target hemoglobin level despite using 300 units per kg weekly of EPO subcutaneously, or 450 units per kg weekly IV, or a darbepoetin dose of 1.5 macrograms per kg per week. Say for a 60 kg person, 300 units would be 18,000 units per week, and it would be 75 microgram of darbepoetin per week. Despite using this dose, if we do not get the target hemoglobin level, then it is labeled as EPO hyperresponsiveness. Now the causes. First and foremost, what I frequently tell my patients, that if you do not have enough ration in the kitchen and you call a cook, wo khana kaise banayega? So the most common cause of hyporesponsiveness is iron deficiency, B12 folate deficiency. That is why KDIGO says that before starting EPO, you replete the patient with iron. You ensure that the TSAT is more than 30 and the ferritin is at least 500. Then you should begin with erythropoietin. Next is the functional iron deficiency. So CKD being an inflammatory state, hepcidin is very high. And we know that hepcidin inhibits almost all steps of the iron mobilization. So you may be having iron in your RE cells, but it is not mobilized to the bone marrow. So you need to get rid of the inflammation. And here is where the HIF-PHI, the newer drugs also come into play, because they also treat the functional iron deficiency. Next is very commonly the infection. If a patient with CKD is presently infected, no matter how much EPO you give, it won't respond. Inadequate dialysis. If you haven't dialyzed a CKD patient well, EPO will not work. Secondary hyperparathyroidism. We know that if the PTH is very high, it can cause bone marrow fibrosis. It can cause mineral bone disorder. So we need to ensure that the mineral bone disorder is also adequately treated. So all these causes, if we treat, then we will be able to treat the patient better.
So we are running late, so I will discuss one or two questions on the kidney transplantation. Dr. Vaidya, as per THOA, who is eligible to donate the kidney, living donor in India? And also highlight the concept of marginal donor, specific donor with diabetes and hypertension.
So Tissue Transplant of Human Organ Act, this was enacted in 1994, and then it was amended in 2011, and now there is update in 2020. According to the latest act, the persons who can donate kidney are near relatives. That is parents, son and daughter, siblings, sisters, brothers, and then previously grandparents were not allowed, but now grandparents and grandson, they can also donate the kidney. So this is near relative, this is one change. And then non-near relatives. Like any person can donate kidney, but that should be for the good cause. There should not be any kind of transaction. And that is only for emotional or good purpose. And third important group of donors is when we are doing swapping of kidney transplant for unsuitable donor and recipient pairing. In that condition, we can do non-near relative donation. So these are the patients who can donate kidney to the recipients. Now regarding the marginal donor means usually there are certain criteria regarding the age, blood pressure, diabetes, BMI, and in that particular group only the patient should be able to donate the kidney. But if you extend the criteria and when you relax the criteria, then this is known as marginal donor. And the graft survival of marginal donor, that is as good as disease donation, but of course it is inferior to the living donation. So first criteria is criteria of age. Usually we don't have much evidence of donor beyond 70 years of age. But now the marginal donor means if the age is even more than 70 years and the GFR of the patient is good, that is normal, and if the person doesn't have any comorbidities, then this group of person can donate. So that means it is not the chronological age, but in fact this is the biological age of the patient that is more important. This is regarding age of the patient. Second important parameter is hypertension, whether we should take kidney from hypertensive donor or not. So blood pressure means blood pressure less than 140, hypertension means blood pressure more than 140/90. So even if the patient is hypertensive, then we can ask for lifestyle modification, diet modification, and if the blood pressure reduced, then very well you can go for donation. But even if the blood pressure is higher and the patient is on one drug or something like that, and there's no target organ damage and the GFR is normal, ECG and echo is normal, so there's one group of center that they accept this group of patient even if the patient is hypertensive. Third important parameter is BMI of the patient. If the BMI is more than 35, that is not an absolute contraindication of transplant. But of course, lifestyle modification and weight reduction, that should be done. But if the BMI is more than 40, then probably this is absolute contraindication. And before going to donation, one should reduce the weight, reduce the BMI, either by bariatric surgery or by some of the medications which is nowadays are used for weight reduction, especially the weekly injectable GLP-1 receptor agonist. So this is all about BMI. What about the diabetic patient? If the patient has frank diabetes, there is impaired fasting and impaired postprandial glucose, then this group of patients should not be accepted as a donor. But if the patient has only impaired fasting glucose tolerance, then again lifestyle modification should be advised. If the blood sugar comes down to normal, then the patient should be accepted as donor. And even if there is impaired fasting glucose tolerance and after lifestyle modification it doesn't come down to normal, then there are certain centers which accept this group of patient as a donor. So there are other parameters also like cyst in the kidney, stone in the kidney, cancer in the kidney. So there are relaxation in each and every parameters, and this is known as marginal kidney donation. Thank you.
Thank you, sir.
Thank you.
Just one. The good part, a great part of this kidney donation is a disease donation. Basically, somebody dies in the ICU and in the ventilator, and my family wishes to donate the kidney. that donation that should be encouraged. Disease donation is one of the important donation because two person can get get kidney from a single person. There is a simple form available, form 7 in the Noto website. You just scan it, and all of us can pledge our organ. At least fill up the forms, and that will be noted. And fortunately or unfortunately, if we die in the ICU in the ventilator in a brain dead situation, then family members, if wishes, then there will be acceleration of the process. The legal and this technical issues will be much less in donation, and that should be encouraged. With that we can do, all of us, every doctor can pledge their organ after death. That is an important part of organ donation.
Thank you, Dr. Pratik Das.
Thank you.
Dr. Vivek Goyal, Dr. Vedya, and also thanks to Dr. Lalitha Dawar, our expert opinion. Thank you.